So coming to the venous drainage, 60% of the blood is drained into the right atrium via the coronary sinus. And the remaining 40% is drained to all other chambers of the heart via the anterior cardiac veins and the venae cordis minimi, which are also called as the Bayesian veins. They are very, very minute veins which drain into all the chambers of the heart. And this coronary sinus, it drains the territory of the heart, that is the area of the heart that is supplied by left coronary artery. And these anterior cardiac veins, they drain the area that is supplied by the right coronary artery. So this coronary sinus is a wide channel of about 3 centimeters long, lodged in the posterior atrioventricular groove, accompanied by the right coronary artery and the circumflex artery. And this coronary sinus is formed by the great cardiac vein. And lodging in the posterior atrioventricular groove, the coronary sinus opens into the right atrium. This is the cut section. This is the right atrium. This is the right ventricle. So this coronary sinus is opening into the right atrium. This is the coronary sinus opening between the inferior vena cava opening and the right atrioventricular orifice. And this coronary sinus, which is opening into the right atrium, is guarded by the Bayesian valve. And this coronary sinus opening forms a boundary for the triangle of Koch, which is formed by the tendon of Todaro and the atrioventricular orifice of the right side and the opening of the coronary sinus itself. So this forms the triangle of Koch, which lodges the AV node, that is the atrioventricular node. So the tributaries of the coronary sinus are the great cardiac vein, the middle cardiac vein, the small cardiac vein, and the posterior vein of the left ventricle, and the oblique vein of the left atrium. So all these, they form the tributaries of the coronary sinus. All tributaries have valves except the oblique vein of left atrium, which represents the remnant of the the left duct of Cuvier. So let us see each in detail. The great cardiac vein. This is the great cardiac vein. So it collects the blood from the apex and is seen in the anterior interventricular groove, which is accompanied by anterior interventricular artery, winds round the left border and then joins the coronary sinus. And the left marginal vein is joined near its termination into the coronary sinus. So there is a valve at its entry into the coronary sinus, which is called as valve of Vuissens. We have seen the annulus of Vuissens, which is the anastomosis between the right and left conus artery is there. This is called as valve of Wissens, where it is a prominent valve of the great cardiac vein, where it is entering into the coronary sinus. So the coronary sinus is bound on both the ends by valves. The end where it is entering into the right atrium, draining the blood into the right atrium, is guarded by the Thebesian valve, and the other end of the coronary sinus, where the great cardiac vein is joining the coronary sinus, is called as valve of Wissens. Coming to the middle cardiac vein, the middle cardiac vein also drains blood from the apex of the heart and is seen in the posterior interventricular groove, accompanied by the posterior interventricular artery and the diaphragmatic part of the anterior interventricular artery. So this ends in the right end of the sinus before the coronary sinus is draining into the right atrium. Coming to the small cardiac vein. So this is the small cardiac vein. Okay. So this small cardiac vein is in the right part of the atrioventricular groove on the posterior aspect. So this is what is the atrioventricular groove on the posterior aspect. So this small cardiac vein is seen lodged in the right part of the posterior aspect of the atrioventricular groove, accompanied by the right coronary artery, and this opens into the right end of the sinus, where it is joined by the right marginal vein. So coming to the posterior vein of the left ventricle, it drains the diaphragmatic surface of the left ventricle and drains almost into the middle of the coronary sinus. So coming to the anterior cardiac veins, which contribute for the 40% of the blood that is drained into the right atrium, as the 60% of the blood volume is drained by various other tributaries, which are in turn draining into the coronary sinus, which is opening into the right atrium and is guarded by Thebesian valve. So these anterior cardiac veins are about 3 to 4 in number, and they drain directly into the right atrium, opening via the foramina minimarum. And there are other veins which are called as venae cordis minimi, which are of much more in number, and very small veins, the tributary veins, which are opening into all the chambers of the heart, right atrium, right and left ventricles via the foramina minimarum, and they are more seen in the atrial septum. And coming to another vein, which is the tributary of the sinus venosus, which is called as oblique vein of the left atrium. This is seen on the posterior surface of the left atrium here, and joins the left end of the coronary sinus. This is the remnant of the left duct of Cuvier, or in other words, it's the left common cardinal vein, and upper end is connected or attached to the left superior intercostal vein, which is in turn a tributary to the left brachiocephalic vein. And the attachment for this oblique vein of left atrium to the left superior intercostal vein is via the fibrous thread which passes through the free margin of the ligament of the left vena cava, which is nothing but a serous pericardium. Coming to a few of the developmental anomalies, or the variants we can call it as, it is the myocardial bridge, which is a congenital anatomical variant that occurs when the coronary arteries pass through the myocardium. That is, the myocardium forms as a tunnel over the coronary vessel. So usually the coronary vessels are epicardial in course, that is, they are on the surface. As we said, they are within the grooves on the external surface of the heart. So it so happens that this myocardium grows over the coronary vessels. So the coronary vessels dips into the myocardium and then is seen again on the surface of the epicardium, that is the surface of the heart. So this part of the area where the coronary artery is underneath the myocardium is called as myocardial bridge. So this usually is not known, but it's an incidental finding during the autopsy. So less frequently it becomes functional. Otherwise, the coronary circulation is almost near normal. So this is considered as a forgotten cause of acute coronary syndrome, which means that the blockage of the coronary arteries. And this myocardial bridge is usually seen affecting the anterior interventricular artery or the left descending artery. Each time the heart squeezes its blood into the circulation, this myocardium also contracts. So during that process, it compresses the vessel underneath it, reducing the blood supply to the distal part of the myocardial bridge where the concerned artery, the coronary artery, is supplying, which leads to infarction or ischemia. So which causes a bit of concern, where these myocardial bridges can be spanning from few millimeters to 10 centimeters or more. And the larger the myocardial bridge, the more the symptoms are seen. So to diagnose the myocardial bridge, the key investigations are CT scan, cardiac catheterization, and stress ultrasound. That means the ultrasound that is taken in between, that is before and after the treadmill tests. So that will determine the caliber and the functioning of the coronary artery. And the only procedure, the treatment to deal with myocardial bridge is myotomy. That means cutting this part of the myocardium, which is called as unroofing surgery. So the roof that is being formed by the myocardium over the coronary vessel is to be cut. So that stands the first line of the surgical treatment, and is the only treatment to treat the after effects like myocardial infarction and ischemia leading to the angina and its further pathology. So coming to the applied anatomy, the main applied aspect of the coronary arteries is the coronary artery disease. Then coronary angiography to see the flow and the course of the coronary arteries, and percutaneous transluminal coronary angioplasty, which is done for stenting the blocked coronary arteries. CABG means the coronary artery bypass graft, where the autografts are taken and grafted to the coronary arteries distal to the obstruction, and cardiac catheterization. So all these things we'll see little in detail. So occlusion of these coronary arteries will cause the myocardial infarction. If not treated, it will lead to the sudden death of the person because it is all ischemic diseases. So the first and foremost is angina or the angina pectoris. It is nothing but the chest pain or the discomfort that occurs if any part of the myocardium does not get enough oxygen-rich blood. That means if there is any blockage to the coronary arteries, then the area of the myocardium distal to that coronary vessel will receive less amount of oxygenated blood, where it will lead to ischemia. So that causes pain in the chest, where a person feels like pressure or something squeezing in his chest, and the pain can also radiate to the shoulder, left side of the arm, the neck, left side of the jaw, and the left side of the back as well. Usually when such type of a pain is seen, the angina pain mimics the indigestion, that is the heartburn. So that has to be differentiated very well. So this angina actually is a symptom of the coronary heart disease. What is this coronary heart disease? Blockage of the coronary arteries, which is usually seen in adults. So how does these arteries get blocked? This is the normal coronary artery where there is a normal flow of blood. If there is accumulation of the erythematous plaque underneath the endothelium of the coronary arteries, that causes narrowing of the coronary vessel, blocking the normal flow of the blood. So the blood that is reaching the area distal to the blockage will not receive the oxygenated blood, that is the rich oxygenated blood, because the coronary arteries have the richest oxygenated blood. So in reversible angina, where there is blockage, that can be treated by the bypass graft or by stenting. The area that is distal to the narrowing of the vessel can be revived, which is called as reversible angina. Whereas what happens is, if this uh, the erythematous plaque formation is not noted, and the symptoms like heart burn or the chest pain and these pain which is radiating to all these areas is being ignored, then the erythematous plaque forms more, and there can be a breach in the endothelial layer over the erythematous plaque. So whenever there is a breach, we all know that the red blood cells, they get accumulated there to form a clot. So this clot, the formed clot, may get dislodged, forming thrombus, and get the other areas of the coronary artery occluded, which is called as progressive angina, which is very dangerous and is always mostly is associated with heart attack. So that has to be kept in mind. So there are different types of angina: the stable, unstable, and vasospastic. And as we said, stable is because of the narrowing, so it demands more of blood distal to the narrowing of the vessel. Unstable is because of the thrombus, which is dislodged at one place and can go and block the other areas of the coronary arteries, where it is very unpredictable and will lead to heart attack. And vasospastic is, it is the spasm that is created in the wall of the coronary vessel. There is no accumulation of the erythematous plaque or anything. It is just because of the spasm, which is called as Prince-Mettels angina, the coronary artery spasm. It is also called as variant angina, which is not concerned with having an erythematous plaque, but the patient feels the pain even at rest. Otherwise, in reversible and the progressive anginas, the pain is felt during strenuous exercise and any strenuous work. But here, the pain is felt even during rest. So it is also called, for that reason, as rest angina. So this has to be dealt very promptly by giving calcium channel blockers, which are the drugs which are used in hypertension, which decreases the hypertension, like amlodipine, and beta blockers like propranolol and all. So these nitroglycerins are given as IV infusions.